Hi, everybody. I'm Eddie,
I'm Raj.
I'm Ashwin.
and this is Blood Cancer Talks, a podcast dedicated to hematologic malignancies where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today, we're delighted to talk about the management of Hodgkin lymphoma in older and frail patients with Dr. Andrew Evans. Dr. Evans is Professor of Medicine at Rutgers Robert Wood Johnson Medical School, as well as Deputy Director of Clinical Services at Rutgers Cancer Institute and Associate Vice Chancellor for Rutgers Health. And of course, he is also an expert in all things Hodgkin lymphoma, especially in the treatment of elderly patients. Dr. Evans, thank you so much for joining us today. To begin with, before we dive into Hodgkin lymphoma, could you tell us a bit about yourself and how you came to be interested in lymphoma?
Sure. Thank you so much, Eddie, Ashwin, and Raj, for being here. It's really great that you guys do a fantastic job of letting not just the country, but the world know about these important issues. Yeah, I finished my fellowship, hard to believe, a little over 20 years ago at Northwestern in Chicago. It was a bunch of lymphoma riches in terms of mentors for me at that time. It was Dr. Leo Gordon was my main mentor. He was at the time very integrated along with Sandra Horning as a chair of ECOG, and Northwestern's an ECOG committee. Leo was a vice chair. Dr. Jane Winter, who was recent ASH president. Steve Rosen was a cancer center director at the time, who's now at City of Hope, was a great mentor. Marty Tallman, who is acute leukemia, as you guys know, MPN, MDS, but really learned a lot from him. And yeah, how did I learn? I think I just very quickly glommed on to it, working in one of Leo's and Jane's clinics. And then for one reason or another, I don't know why, but as a fellow, I went to my first ISHL, the International Society of Hodgkin Lymphoma meeting. At the time, it was every 3 years. Now it's every 2 years. All the world's experts meet in Cologne, Germany, which is again this Oktoberfest. That's not a mistake, but we're smart. We enjoy Germany in October, but it's just an amazing meeting. And I think it was at that meeting that I not only fell in love with lymphoma, but specifically Hodgkin lymphoma. And as you guys know, it's just one that's steeped with rich history and just so many different variations, the younger, the bimodal, the older patient population, all the way from the diagnostic component to obviously the treatment and the survivorship. So that's the quick story.
No, it's great. It certainly depends a lot who you end up being mentored by as to where you might be steered. I'll start with a case to contextualize some of our discussion. So we've got John, who's a 78-year-old man with a history of hypertension, type 2 diabetes on oral hypoglycemic agents, and osteoporosis. And he's from home with his spouse, who helps him with some activities of his daily living, such as cleaning and shopping. And he uses a four-wheel frame to walk outside the house. And his cardiac ejection fraction is normal. And so with that case in mind, I want to start with a general question, which is to say that, of course, as you mentioned, there's a bimodal distribution of patients with Hodgkin lymphoma. So about a quarter of patients are in the older or over 60s category. And of course, as with other malignancies, advanced age is one of the adverse risk factors. And so I wanted to start by asking you, when you're thinking about or about to see an older patient with Hodgkin lymphoma, what information do you gather and how do you distinguish between fit older patients, unfit older patients, and frail patients?
Yeah, sure. And of course, Eddie, you started with the most challenging case because I'll think about it, and even though every patient is different, I say every patient's a snowflake. We have three categories, and really thinking about it through the lens of geriatric assessments. And we can mention what's the best one to use. There isn't one, but there's the ones to be thought of. At a bare minimum, I would say, would be thinking about activities of daily living, which you were hinting at. And it sounds like that patient has some limitations in instrumental ADLs because there's self-care, bathing, dressing, toileting, feeding yourself, and then there's the instrumental. And then it's comorbidities. And there's different scoring systems for that. The one that we've used in literature and the one that I'll use in the clinic is the CIRS, C as in cat, IRSG score. And those take about a little over 5 minutes actually to calculate if you have a good medical history and all of that. But if we use what is available in lymphoma, there was this criteria called the Tucci criteria. Dr. Tucci in Italy had established based on age, using 80 as a cut point, ADLs, any loss, and as we said, in terms of fitness. This patient, by the words of it, would sound to be unfit, but not frail. And because ones who are fit, meaning preserved ADLs, comorbidities, at least with a Surge G less than 10 and less than 80, we think are fit for full dose anthracycline. And I would treat generally like a younger patient, except I would not give bleomycin. That's like to me, its risks outweigh any benefit. And then you have the other end of the spectrum where someone isn't just you said it sounds like using a walker of sorts. So someone's in a wheelchair, they lost self-care, et cetera, who you're thinking about some single agent, if not palliative. But this patient is right in the sweet spot, and it's very difficult. It is very difficult because where we are in Hodgkin's right now, there isn't actually a published like a mini CHOP. We have in diffuse large B-cell lymphoma. We do have a clinical study looking at a mini AVD, but to me, that's really the key question. Is the patient an anthracycline candidate or not? Because we know even in data within older patients with Hodgkin's, that's critical to cure. It's not that you can't have long-term survival. It's just going to drop about 30 percentage points if an anthracycline is not used.
Regarding the next thing I wanted to ask is that what's your approach to pre-phase steroids in older patients with Hodgkin lymphoma? Do you use them like only in selected cases, and in cases where you use them, for how long and what dose do you use for pre-phase steroids?
Raj, if you looked up pre-phase in Webster's dictionary, you'd see a picture of me with a flag. I am a big fan of pre-phase in most patients. And I see really, and the reason I say that, it's really important in older patients. The reason I say that is especially for even a younger patient who's having debilitating B symptoms or tumor in the chest causing symptoms, and they've had their PET scan. You need to be careful with steroids and a PET scan, but even just a pulse of steroids, to me, at a minimum, will just garner relief of symptoms. Where there's some data, not as much as we'd like in older patients, the question is, can it mitigate treatment-related mortality? Because when we think Hodgkin lymphoma, we don't think treatment-related mortality, but in almost every series, especially older series using bleomycin-based therapy, the treatment-related mortality to Hodgkin, frontline Hodgkin treatment, and is anywhere from 3% to 15%. Actually, using BIACOT baseline in a German study, a subset of HD9, the treatment-related mortality was 21%. As you guys probably know, Dr. Freundschuh had some nice data published. It wasn't a randomized study, but it was a look back before and after pre-phase, because if you're going to see it, more often than not, at cycle 1, patients are the most frail, are not just from their pre-existing comorbidities, but their disease. And so I think there might be benefit, but I admit that's not proven. And the third reason I like a pre-phase is it's very difficult for some of the instrumental ADLs that will potentially determine fit or unfit. Were those pre-existing, or is that assessment you're doing due to their disease that might have been present for 6 months? Because I've had some patients, you give they're unfit or even sometimes frail, you give a pre-phase, now all of a sudden they're fit. And so that's actually what we designed in our current clinical trial that maybe we can talk about later. It's an investigator initiated with Craig Portell, is we're giving a pre-phase geriatric assessment, pre-phase, repeat the geriatric assessment.
And I think, yeah, that's very helpful. And also, as you mentioned, that anthracyclines are critical for cure. So how important do you think it's to include anthracycline in the treatment regimen for older patients in Hodgkin? And how do you make that decision in whom to use? Is it just based on the SIRS scale, geriatric assessment, or the response to pre-phase steroids? Or how do you make that decision?
Yeah, it's for the fit patients, it's a little clearer discussion. So someone under 80 with preserved ADLs, comorbidities less than 10, because you can get a score with each comorbidity, and so less than 10 when you accumulate it up. It's those unfit, and let's say they're unfit even after a pre-phase. It's case by case, I'd have to say. You could say it's almost like that for not just Hodgkin lymphoma, but any lymphoma, diffuse large B-cell. And I think it's more than a gestalt. It's obviously we involve at least we have a cardio-oncology program, so we'll involve them. Is there anything we can do to tune them up? what could be, are they on all the right, are they on aldosterone, are they on the different fancy drugs that are out now in terms of that ejection fraction, and we'll try to make a combined decision on that. And we try not to be overly aggressive, but if after discussion with the patient and the goal is cure, meaning at least long-term 5-year plus survival, we'll use an anthracycline. We really will. Now, we'll check them extra close. We'll have them see cardiology every other, if not every cycle. We'll repeat EF assessment every 2 cycles. It's not like you just give it and see you back in 6 months. Obviously, they have to be followed very closely. But that's just a completely unmet need. And I would argue in all of lymphoma, not just Hodgkin's, these patients, because aging society, we're only going to see more and more of this issue in terms of those tweeners, those gray zones of who should and should not get anthracycline. And I'll just also add, we highlighted this, it shouldn't be an all or none. What about reduced dose anthracycline or other modifications?
You briefly touched on earlier about the bleomycin toxicity, which is primarily lung. First question is, what is the mechanism behind that? And second, it is completely driven by age. In some studies showing that more than 20% at the age of more than 60 years. And these also can translate into mortality in this patient population. So should we be avoiding bleomycin in all old adults with Hodgkin's lymphoma?
Ashwin, great question. And so I would say that one quick answer is over age 70, I would say yes, do not give it to anybody. 60 to 70, you could say case by case. But to your point, it's a bit of Russian roulette, meaning we went back and looked at one of the most recent clinical trials. If you remember E2496, that was the ABVD versus Stanford 5 in the US advanced stage study. And the risk of it was 25%. And these are a cooperative group. Usually they're fitter patients, 25%. And the fatality rate was north of 10%. And I can tell you in patients who developed it or died, we could not find a risk factor. We looked at smoking, we looked at pulmonary function tests, we looked at ejection fraction. The only thing that predicted, and I think this is key, one of the keys, is actually of the patients who died, all but one received ABVD, not Stanford 5. And why is that important? ABVD has double the bleomycin. So it's just double the chances of insults. The other important point that you highlighted is age. Yeah, it's almost exponential, the risk of it, over 60 by decade, 60 to 70, 70 to 80. So the reason to your point about mechanism, so one is it's renally cleared. And as we know, aging, so it's just going to have issues and issues with renally clearing it. And believe it or not, if you really dig into the literature, there's actually, I'll use the word elegant mouse studies with bleomycin. It's thought to be free radical mediated. And that's why there's also some, I'll say, soft data that when you use growth factor, which we know attracts free radicals, neutrophils to the lung parenchyma, that there might be an even higher risk with growth factor in bleomycin. So it's thought to be free radical mediated. And I know there's some data that says it might be helpful in younger patients, but I would just say if you're going to use it in anyone over 60, just have a very short leash to stop it. I would ask every 2 weeks, any cough, shortness of breath. You can't really rely on PFTs. Sometimes you even see it on a PET scan before a patient. It bizarrely localizes to the upper airways. Just have a very short leash. I just think, to me, it's hard to predict, and I will leave it out more often than not.
So should we avoid GCSF completely in older adults who are receiving bleomycin?
That's the paradox, because if we say who is the patient because of combination chemo who would benefit most from growth factor due to the anthracycline, is that. And so that's why I feel I can use growth factor with more impunity, whether there is or isn't a risk. I think there probably is a slight risk. Is it because I would say they benefit from growth factor, even if you're not giving brentuximab vedotin or nivolumab, which I'm sure we'll talk about. So it's not a worry for me because I'm more often than not giving bleo and yes, giving prophylactic primary growth factor prophylaxis.
Yeah, it's tricky. Damned if you do, damned if you don't. But yeah, you hinted at brentuximab vedotin, of course, anti-CD30 antibody drug conjugate. So let's talk about that next. And I suspect listeners will remember the Echelon 1 study, which was a phase 3 randomized trial comparing 6 cycles of BV plus AVD against 6 cycles of ABVD in patients with newly diagnosed Hodgkin lymphoma, which of course showed both a modified PFS and overall survival benefit for the BV arm. But I want to drill down specifically and focus on the cohort of 186 patients who are over the age of 60, where there was an improvement in 5-year PFS, 67 to 61.6%. And so I wonder if you might recap the results in this group and maybe tell us about the lessons from this trial and for this regimen in older patients with Hodgkin lymphoma.
Yeah, I think it was one, like a lot of trials. I'll just say the first thing is it's great that we're including older patients in these Hodgkin studies, because I can tell you, I was really practicing, but before 2000, less than 3 to 5% Hodgkin, non-Hodgkin patients over age 60 for Hodgkin's, I'll just say, were included in studies. So at least that was about 10%, a little more of the population, which is great. Maybe not quite in the real world, like you highlighted, 25%, but certainly better than historical. So that's great that they were included. What wasn't great, and again, we just didn't appreciate at the time, is it's difficult to treat a 65, 70, 75-year-old identical to a 22-year-old. It's not surprising they're going to have more toxicity. And that's what was seen in Echelon 1. You did highlight it was numerically better progression-free survival. It wasn't large enough to have a statistical significance. But not surprisingly, there was a lot more neutropenic fever when it's given concurrently. And that's an important point. With the brentuximab vedotin AVD, it's given at the same time. I can mention a sequential study we did as well. And a lot more peripheral neuropathy. North of 30-35% of patients had grade 2 or worse. Grade 2 or worse means adversely affecting your instrumental ADLs. And that was a lot. And it was much more than ABVD. ABVD still had plenty of neuropathy. But I think that's just some of the lessons learned, that we have to think of the older patients differently. Great that we're including them in clinical trials, but I think we need to evolve to a place, even though it's a lower subset, where maybe if we can't do their own study in the cooperative groups or other groups, maybe just some subset where there's dose modifications and some way that they can have it more tolerable.
Yeah, I think it's a nice segue to talk about your studies. As you try to improve upon this regimen of concurrent BV AVD in older adults, and you have designed this study of sequential BV followed by AVD. So can you tell our audience as to what was your thinking behind the design of that regimen and a little bit about the trial?
Yeah, sure. That was a multi-center investigator-initiated study. It was co-designed, I would say, with Paul Hamlin, a good friend and excellent lymphoma colleague at MSK. And we designed it actually, was it before? It was at worst at the same time E1 was being set up. And it was really just predicated on a couple critical points. One, of course, efficacy. We wanted to be better than historical past. And when you looked at ABVD data, the 2 to 3 year PFS is probably in the 50 to at best 60% range for older patients. If you look at any study at 2 or 3 years is the level. And there is some that were even worse. So that was one, efficacy. Of course, 2, tolerability. And we just rationalized without having E1 data that it would be too much from a neuropathy standpoint, kind of 2 Vinca-like medications. So that led to the sequential. And the third was going back to the pre-phase discussion. Because on this study, new patients, you could be fit, unfit, receive 2 doses of brentuximab vedotin 3 weeks apart. And by the way, the response rate to just 2 BV was around 80% with about 35% CR. Then you went on to receive AVD, no bleo, and then more BV. If I had to go in a time machine and change it, the only downside in a way is long treatment, because BV, 6 cycles of AVD and then BV. So it was pretty long. But what I can say, markedly better tolerated than E1 or ABVD for older patients. And it partly was, I think really a lot of it was at prephase, because most patients with cycle 1, whatever disease-related symptoms they had were gone, and their strength, and they were more vigorous and could tolerate that first cycle and move on. And the long story short, the 2-year PFS, hard to believe, but true, 90% in that study for older patients over age 60 advanced stage. And so we were pretty happy with that. But of course, it's never perfect. And the hope would be, can we keep it up there pretty darn high? but do it where it's less treatment and maybe more targeted drugs.
Do we have long-term follow-up data on the relapse risk with that regimen, or is the follow-up still pretty short?
We don't. It's a study when I was at Northwestern still, so I've lost a little bit of control over it, so to speak. We've tried to dig it up. MD Anderson was on it as well. It looks like it's durable, but I would be hesitant to give even anything verbal off the record on that. There was a real world on it that it was published or at least presented at ASH, and it looked to be in the range when they looked at 3 to 4 year. It didn't stay up at 90, but at least still hovered around the 70% range, which for older patients is great when you're at least comparing to historical control.
Yes, if we can dig in a bit more into the results of that trial, because that sort of builds the landscape for the next question as well. You mentioned the response rate after 2 doses of brentuximab, 80%, and CR rate about 36%. Could you tell us a little bit more about how that developed after the AVD and the proportion of patients who went on to have the kind of BV consolidation, and then what the toxicity looked like in that trial?
Yeah, we ended up after the end of chemo, before the then single agent, I'll say the word consolidative brentuximab vedotin, of a CR rate of 90%. Basically, everyone was in a CR, I should say. There still was AEs, there's no doubt about it, but at least when we compared it to E1, it certainly was much less neutropenic fever, much less neuropathy, and importantly, like almost no grade 3 neuropathy, because grade 3 neuropathy is affecting your self-care ADLs. Again, toileting, eating, dressing, etc. You'd like it to affect no ADLs, but certainly not self-care. And so that was quite low. And a problem in some of when you give, a lot of that's just dependent on number of doses of BV. So I think the fact that we only gave 6 or so doses of BV was much less, because when you give E1 like treatment, if you give the first 6 cycles, that's 12 doses of BV, brentuximab vedotin, and there's definitely going to be more neuropathy with that. But it was really very manageable, and frankly could see not much different from a ABVD like study. Obviously it wasn't randomized. I'd be cautious to say it was better or tolerated than an ABVD regimen. But one note I will say, Eddie, is small numbers, because it was only around 40 patients, a little north of 40 patients, was we did geriatric assessments, but again, not being as smart as we could be at the time, we allowed some unfit patients in, and those patients did much worse. Maybe not a shocker, but around 10-ish of the patients were unfit. And so when you looked at the fit patients, the PFS was actually close to 100%. And unfit, the only reason it was dropped down was probably around 40 to 50 for unfit. And I would be hesitant, granted small numbers, and it's probably more the anthracycline part, for a bona fide unfit patient to think about that, which is those are the patients that we need more kids' gloves.
Yeah, totally. So I guess we've spoken a bit about concurrent BV-AVD in Echelon 1. We've spoken a bit about omitting bleomycin. We've spoken now about sequential brentuximab and AVD. But I want to build on that and talk about the SWOG 1826 data that were presented at ASH last year. So for anyone who missed our fantastic episode with Nancy Bartlett, we talked about the main data that came out from SWOG 1826 at ASCO 3. So please go back and check it out if you haven't listened. But 6 months later at ASH, we had the subgroup analysis for the elderly patients, the patients over 60. And this provided some very enticing data for this subgroup. And so to recap, SWOG 1826 was a large randomized phase 3 trial in both children and adults with Hodgkin lymphoma, comparing 6 cycles of nivolumab, a PD-1 inhibitor, plus AVD, with 6 cycles of brentuximab vedotin plus AVD. So it wasn't PET adapted, it was just 6 versus 6. And there were about 97 patients over the age of 60 with a median age of 66. And so first I wanted to talk about toxicity. What did you notice, and what were the rates of toxicity between the 2 different arms in the patients over 60?
Yeah, and I want to give a call out to a couple people before I talk about the data. One is the lead author, and that is Dr. Sarah Rutherford, who is a faculty member at Weill Cornell. She led this for Alliance, but she led this older patient subset analysis, pre-planned subset analysis of about 100 patients, half getting Nivo AVD, half giving E1-like therapy, the BV-AVD. And then I do want to also just quickly mention, we probably don't have time to talk about it, is there was a contemporaneous phase 2 study of Nivo-AVD that Paul Vitorka and Alison Moskowitz from MSK did, which basically showed the same thing. Theirs was a phase 2, and this was obviously a cooperative group. But it was great to see the same thing. In terms of tolerability, one thing with the checkpoint, of course, we're always at least raises to the top of the mind is what about autoimmune checkpoint-like toxicities? And I whether it's because of concurrent chemotherapy or because of the older patient population, maybe a compromised immune system to some respect, we saw very little autoimmune-like AEs. The only one that really came out, interestingly, was thyroid. So a little bit of hypothyroidism and a little bit of hyperthyroidism as well. But we're talking about 15% overall and grade 2 of 2% or so. What's interesting is when we looked at rash, liver function tests, pneumonitis, gastritis, colitis, no difference between Nivo-AVD and BV-AVD, interestingly. They were both low, but no difference. And the other one, again, was low, but it's still the hypothyroidism in particular was something that was flagged. But again, grade 3 was only 2%. And partly because there was not concurrent BV and vinblastine in the Nivo-AVD, the neuropathy was much less, as you might imagine. Overall rate, as well as grade 2, grade 3 with the Nivo-AVD. Neutropenic fever was actually relatively low in both arms. That's a little misleading because almost every patient with BV-AVD received growth factor, and around half or less of Nivo-AVD received growth factor. So despite half as many receiving growth factor, there were similar rates of infection, neutropenic fever in both. And otherwise, Eddie, in terms of tolerability and AEs, there was not much difference.
Yeah, to recap the numbers, as you said, 69% got GCSF Nivo, whereas 90% got it in the brentuximab arm. And there was a difference in bone pain, small difference in febrile neutropenia, about 6% higher in the brentuximab arm. And the sensory neuropathy, as you mentioned, all grades 30% versus 66%, so more than double the amount of peripheral neuropathy in the brentuximab arm, and greater than or equal to grade 3 was 11% compared to 2%. So quite a bit more grade 3 peripheral neuropathy, which, as you mentioned, it can be quite disabling when it gets to grade 3. So now if we move to talk about efficacy, what were, from Dr. Rutherford's presentation at ASH, what were the top-line findings for efficacy between the two regimens in older patients?
Yeah, this was a surprise, the magnitude of benefit, I would say, to Nivo-AVD versus BV-AVD. And with the caveat that with all of the presentations last year in 2023 off of 1826, it was only 1 year follow-up. You'll be seeing in the very, very near future about the 2-year follow-up data on the main study. But at 1 year, again, only in the older patients, it's hard to believe, but it was almost a 30 percentage point difference at 1 year. In other words, Nivo-AVD 1-year PFS 93% and BV-AVD 64%. And as you might imagine, that's an event-free survival as well. And it was a trend for overall survival at 1 year, and which you just usually don't have overall survival until 5, 6, 7 years in Hodgkin's, if you see it at all. So it was pretty surprising to see such a magnitude of benefit. Of course, we need to see durability in that, not just even at 2 years. Yes, we want to see 2 years. That's usually the most common publication point for many, but 3 to 4 and beyond.
Yeah, and so now the tough question, which is if you've got someone who's at the fitter end of the elderly Hodgkin spectrum, how do you choose and which regimen do you prefer now that we've got all those different trial data for older patients with Hodgkin lymphoma?
Yeah, even though I am incredibly biased with the sequential BV-AVD study for obvious reasons, no, I would say at least as of ASH and certainly in the last few months, it's Nivo-AVD for a fit older patient who we think can take full dose anthracycline. That's the standard of care. I think it's difficult not to when you see that data, even though the median follow-up is at 1 year. And yes, we want to follow that through. But even if you would say it was the same PFS with less toxicity, you could make an argument. But now we have a double positive, so to speak, less toxicity and significantly better progression-free survival. So that's what we're working off of. We do have a clinical trial I can mention too, maybe if of interest, but yeah, that's a current standard.
All right. So now moving on a little bit more on patients who are too frail for any chemotherapy. So for patients who might be too frail for any chemo, as the trials testing single agent BV or single agent PD-L1 inhibitor have shown limited success. Can you give us a summary of of the trials single agent BV or single agent PD-L1 inhibitor? What is their response rate and the durability in this population, and how do you approach these patients?
Yeah, sure. And obviously, Raj, even within the frail, there's going to be different buckets and subsets. But if we just take a real bona fide frail, meaning not due to disease, that they're either over 80 and unfit or less than 80, but just with really compromised ADLs and a ton of comorbidities, or let's say the ejection fraction is stable, compensated, but at 40%, 35%. I think most people would not give an anthracycline in that scenario. And that's not an uncommon. That's probably 10, maybe 20% of all older patients we see might fall into that category. And to your point, yes, as there should have been, there were two single agent brentuximab vedotin studies, prospective studies done. And then there were two single agent checkpoint studies. And the word I would use with both, even through the lens of frailty, it was a little disappointing. Interestingly, with the BV dose or the BV studies, the initial remission rate wasn't terrible. You got up to 80, 90%. Unfortunately, it was just not durable in the high majority of patients. It really fell off. And then really surprisingly, to me at least, is the single agent checkpoint studies. You had something like 2-year PFS of 15, 20%. And so now, does that mean more is better? We don't know. It could have been that small phase 2 was just an incredibly super frail patient population, so we have to be cautious. Where I think there's some interest is at least a little ratchet up. And so Jonathan Friedberg recently published in JCO, there were these successive phase 2 studies where they looked at single agent BV, then they did BV DTIC, they even had BV bendamustine, and then BV nivolumab in patients who were, I'm going to say unfit, although they didn't use geriatric assessments. It was a subjective, I don't think they can tolerate anthracycline, but they did really, the median age was mid to high 70s. They really did look like a unfit, if not frail population. And it was a little bit better in that. So if you look to his recent JCO publication, whether the BV DTIC or the BV Nivo, which has some attraction of kind of a double novel targeted agent, we're tracking at 2 years closer to 50, 60, 65% PFS. And it looked like there might have been a tail. So we'll need to see with longer follow-up. I'd like to see at 5 years that, that maybe even if it settles out at 30 to 40%, that population possibly, if not likely, cured without classic anthracycline therapy. But I just want to be careful that we don't throw the anthracycline baby out with the bathwater, because there is that gray zone middle of who needs anthracycline. And I just, sometimes we try to over dichotomize into you're fit, get full dose, or palliative treatment. And to me, it's all an unmet need, older patients, but especially that unfit frail, and working with our cardiologist to say who and who shouldn't get anthracycline. And if so, what dose should we be given certain other medications with it, et cetera.
I was just going to say, yeah, so I suppose it's almost easier to answer for the fit and for the frail, and it's the unfit in the middle that you toss and turn at night and have lots of interdisciplinary discussions about to try and work out what the best approach is. And you mentioned a couple of trials that are underway. Could you give us a sort of spotlight into the future of, we've now got these great S1826 results. We've also got the Boeing results from your sequential study. Where do we go next to try and improve upon that for older patients with Hodgkin?
Yeah, absolutely. And again, I'll just reiterate, the great news is it's just we live in a much better time where there are multiple ongoing phase 2 studies, specifically in older Hodgkin lymphoma patients. That just didn't happen before 2015, 2010. So that's great, number one. Number two, let me focus outside the US. So there are a couple studies, and most studies are looking at integration of checkpoint inhibitor therapy. So there's a study called the INDY study that's associated. Paul Brockelman is leading that. There's another study called the Ratify study that Graham Collins is leading. That's integrating a checkpoint inhibitor to standard AVD, leaving out bleomycin for every patient, which is great. And then, oh, by the way, we all saw the recent BRCAD data published in the Lancet for patients with stage 2B or stage 3-4, which was pretty impressive results. There actually was an elderly cohort to that, so we should be seeing some data very possibly this October at the next Cologne meeting as well from Dr. Brockelman on looking at BRCAD. It'll be interesting because BRCAD is tougher than ABVD or Nivo-AVD, but let's see. And so what we're doing in the US, we have a investigator-initiated study with Craig Portell at the University of Virginia, and it's building off of that sequential study that I alluded to, the BV, AVD, BV. And what we're doing are two things, is actually three things. One, we're starting with a prephase, but it's a brentuximab and a checkpoint pembro prephase for a couple doses. And we're then, that's one. Then two, we're repeating geriatric assessments. And that's what drives the next treatment tree, is the second geriatric assessment. And if you're fit, you'll go on to receive more limited cycles. I think it's 4 cycles of AVD and then more BV checkpoint. For bona fide frail, no chemo, you'll continue checkpoint brentuximab vedotin. And then we have a new study amendment that for unfit, and I know this is segregating it out, but I think that's what you have to do. You have to split hairs with this, is we're actually looking at a mini AVD. And it really is basically just 50% dose reduction AVD for the fit patients. And then they sequence on to BV checkpoint. So that's that study. It's a phase 2. It's more, you could argue, exploratory, but we'll see where that leads.
No, that's very cool. And I think that's prompted a question that I wanted to ask, building on what you said earlier. Obviously, in an ideal world, you have ready access to geriatrics colleagues and cardiology colleagues in real time. So perhaps not everyone everywhere is going to have necessarily that access. So you mentioned the SIRS-G. If you don't have perhaps other colleagues who can help, what else can hematologists and oncologists do to help, divide out or to get more granular on working out how fit the patient is in the absence of interdisciplinary colleagues who can help?
Yeah, that's really important. And I would submit most colleagues, certainly in the community, don't have ready access to a geriatric oncology colleague. Even a lot of academic centers don't. And hopefully that's something that'll improve over time. But let me say 2 things about that. Someone could say, because I keep saying geriatric assessments, comorbidities, someone could say, how do we know that's important? There has been some preliminary data we and others have published that you could say, what about just a general prognostic score like the Hassan-Cleaver-Deal IPS, or what about our new advanced stage HIPI, the Hodgkin's IPI we published in the JCO? Well, both of those, ours included nobody over age 60, and the Hassan-Cleaver-Deal basically had no one over 65. And so you could say we don't know, but someone did test it. Actually, the Danish took the AHIPI and a machine learning model. They published it in JCO Informatics, and they showed that, yeah, not surprisingly, when you use just these basic like white count, albumin, hemoglobin, what's in these scales, completely doesn't calibrate. And by the way, I use that word calibrate specifically. It's probably, I don't know if you guys have talked with Matt Maurer. I've learned so much from modeling on him. We always think of discrimination, but like getting a C statistic, but that's like step 1 to predictive modeling, because C statistic just puts it into high risk, low risk. It doesn't give you accuracy. And so when they tried to do a calibration plot, it just didn't work for older patients. And so I think we're going to have to go down the route of really looking at geriatric assessment. To answer your question more specifically, I would do at least ADL assessment, self-care, and instrumental, and a SIRS-G, at least to try to give you some information. And it's arguably only prognostic of patient outcome, not predictive of treatment. Those are the studies we need to do. We need to take whatever's prognostic and then study it, hopefully in randomized studies at some point, to really prove it's predictive. I will lastly add that a friend and colleague, Stefano Luminari in Italy, if you remember, he published this elderly IPI with diffuse large B cell. they are running a separate Hodgkin's cohort that's not only looking at geriatric assessment and ADLs, but they're also doing things that the geriatric community think are important, like grip strength, like a 6-meter gait, time to get up and go, things like that. Do we really need, which we probably do, makes sense, some literal functional assessments in patients? But that's all great. Again, that's great if we do it to get prognostication. Then we need to put it into clinical trials and hopefully randomize.
Yeah, which sort of brings me to my last question, which is how do you ensure that we can try and recruit truly unfit and frail patients to clinical trials? Because sometimes clinical trial eligibility criteria automatically rule a lot of these patients out. So do you have any specific strategies, both when you're designing the trial and when you're implementing it to try and optimize, try and include as many patients as possible?
Yeah, at least through the lens of the United States, we have to involve our community colleagues. There's no way between it, but otherwise. As you might imagine, and I don't blame patients, elderly in general, much less unfit or frail, yeah, they're not going to want to travel an hour every 2 weeks back and forth from their treatment. They might not be able to do it physically or have transportation. Research is done, in particular a clinical trial, and if it's through the U.S. cooperative groups, yeah, it's gonna have to involve our community oncology colleagues because the patients are there and that's where they are. And to your point, Eddie, which is very good about clinical trial inclusion and exclusion, yeah, we're gonna have to loosen it. Now we have to be cautious. We don't want to just have a free-for-all and all comers with creatinine on dialysis and all of that. Like you have to have some guardrails, but I think we have to widen the guardrails if we're really going to make an impact in this patient population, which in my opinion is only going to become more prominent over time with an aging society, and we know cardiac disease is present.
Yeah, absolutely. Thank you so much for coming on to Blood Cancer Talks to talk about Hodgkin lymphoma, particularly in the elderly. I think that was a great insight from a lot of different clinical trials, many of which you've led, and also about the practicalities of geriatric oncology, which we see very frequently in the clinic. So thanks for joining us, and we hope you'll come back and join us again soon.
Thanks so much.